Hello everyone, welcome to another lecture, and today we'll discuss something about pediatric pneumonias. So this lecture was actually requested by one of my subscribers, so I am fulfilling my promise over here, and I'll be making a video on pneumonia, which will be divided into two parts: community acquired pneumonia, and the second is the hospital acquired infection, which includes a plethora of other types of pneumonia. If you want me to cover a specific topic for you, which you find difficult to understand, please do not hesitate to reach out, and I'll make sure that I'll make a video on that. So let's begin. So pneumonias. So first we'll begin with community acquired pneumonia. So this is per se the most common pneumonia in pediatric population, and as you know, pneumonia is the inflammation of the lung parenchyma. So that is the definition of pneumonia, and pneumonia in pediatric population is usually defined on the basis of clinical features and chest X-ray. So it is one of the most common cause of mortality, along with diarrhea, in even the malnourished and non-malnourished children. So it has to be read out and be known about. So the most common cause of pneumonia in less than 5 years is actually bacterial infection in developing countries, including India, but it is viral in developed countries. So, if someone asks you that what is the most common cause of pneumonia in USA, then it would come out to be viral. But in developing countries, it would turn out to be bacterial again in less than 5 years. Okay, in less than 5 years, it is less than 5 years of age, and the if someone asks you that what is the most common cause of pneumonia in a newborn, pneumonia in a newborn, so it is gram negative enteric bacteria, gram negative enteric bacteria. Okay, and if you exclude newborn, so most common cause of pneumonia from 1 month to 5 years of age, we saw that the most common cause is bacteria. So the most common cause in bacteria is pneumococcus, as you all know, pneumococcus, and it also might be GABHS, group A beta hemolytic streptococci. So the most common cause is pneumococcus, and the second most common cause is group A beta hemolytic streptococci. Even Haemophilus is a common cause of pneumonia. Now, what is the most common cause of viral pneumonia? And the answer to that would be respiratory syncytial virus. It is not metapneumovirus. It is not influenza family. It is respiratory syncytial virus. Now you have to remember that there are some causes of atypical pneumonia. So atypical causes, it might be mycoplasma, it might be chlamydia, and historically we have called these as the walking pneumonia, in which the patient has pneumonia but the symptoms are not as severe as the other pneumonias. Now, in HIV situations, in HIV, the most common cause, the most common opportunistic infection in HIV in India is tuberculosis. And another pneumonia that we have to keep in mind is pneumocystis carinii pneumonia, or pneumocystis jivauracii, whatever you might call it. So it is another cause of pneumonia. Now, in pediatric population, there is one pneumonia that is, infrequently or very rarely seen in adult population, and that is pertussis. Now, we will not see pertussis entirely, but I'll tell you that if a patient presents to you, the age might be range from 2 months to 5 years of age, and if there is complaint of apnea, if there is complaint of the child is crying and suddenly stops breathing, there is whoops, there is whoops. As you know, pertussis is also called whooping cough. It is also seen in mycoplasma and adenovirus, but Again, there is a WHOOP present and there is a severe lymphocytosis. You know, the total leukocyte count is increased to 20,000, 25,000, even 30,000, and out of that 80-90% is lymphocytosis. So this is one of the only bacterial infection which might lead to massive lymphocytosis. So you have to keep this in mind, that pertussis presents with these complaints. Now, what are the clinical features in patients of pneumonia? So in pneumonia you see respiratory distress. That is the feature that brings the patients to you. So what are the features of respiratory distress in a pediatric patient? It might be nasal flaring. It might be fast breathing. As you know, what is the limit of fast breathing? Then it is, you have to remember like this: more than 60, more than 50, more than 40 per minute. Okay. So this is per minute, and more than 30. More than 30 per minute. So this is for less than 1 month newborn. This is 1 month to 1 year. This is 1 year to 5 year. This is 5 year to 12 years. So this is the limit, the upper limit beyond which you will call it as fast breathing. So these are the arbitrarily defined limits. Again, there might be here and there, but these are a basic idea. So the fast breathing is the most common feature, and usually on the basis of clinical features, when we decide the diagnosis of pneumonia, then this is the criteria that we take. Now, this fast breathing, along with it, you might have chest retractions. Okay, so this is present, and along with this, you have other symptoms like irritability or refusal to feed, or you might have respiratory failure, or you might have cyanosis. Cyanosis is again very common with viral pneumonias and pertussis pneumonia, because with viral pneumonia you have something like the associations with bronchiolitis is very common. So now one of the feature is that if wheeze is present, it essentially rules out bacterial pneumonia. Bacterial pneumonia never has a wheeze unless the patient has cystic fibrosis, or patient has a reactive airway disease, or if has something of that sort. You do not find wheeze in bacterial pneumonia. The presence of wheeze, recommends or tells you that it is viral pneumonia, or it might be bronchiolitis. So you have to remember that these are never found, and what we find are coarse crepitations and rails. Now, fine creps, as you all know, that it is present in pulmonary artery hypertension or pulmonary edema. So these are the findings. Again, there might be coughing, low-grade fever, lethargy, weakness. The child is not gaining weight. There is failure to thrive. So all that features are present with pneumonia. So that you have to keep in mind. Now, you have to remember, if someone asks you that what is the most common cause of pneumonia in cystic fibrosis, it is, Staph aureus, and it is not Burkholderia cepacia. Burkholderia cepacia is the specific infection, but Staph aureus is overall the most common cause of pneumonia in patients with cystic fibrosis. Now, again, there might be complications like pyothorax, there might be, hydrothorax, there might be pleural effusion, and all that Now, what is the assessment, or how do you categorize pneumonia? Categories of pneumonia. So these are the categories of pneumonia. One is very severe pneumonia. One is severe pneumonia. One is just pneumonia. And the last one is no pneumonia. So what are the features? When do we call it as very severe pneumonia? If there is central cyanosis, or refusal to feed. The child is not feeding at all. There is convulsion, there is lethargy, there is something known as Austrian syndrome. Have you heard about Austrian syndrome? Austrian syndrome is triad of streptococci infection, and it causes a triad of endocarditis, pneumonia, and meningitis. So, just for your knowledge. So, the child might be unconscious, or the child has severe respiratory distress. Now, for severe category, there is lower chest indrawing or nasal flaring, but there is no sign of systemic involvement or no signs of severe pneumonia. Okay, no signs of very severe pneumonia. Then only you will call it as a severe pneumonia. Now, what is pneumonia? Pneumonia is just presence of fast breathing. So we have seen the arbitrary limits that we have assigned, that more than 60, more than 50, more than 40, more than 30. For your info, I'll just help you with this. More than 60 in a newborn, more than 50 in an infant, more than 40 in less than 5 years, or more than 30 in the elder children is fast breathing. So that is pneumonia, and there are again no signs of severe or very severe disease. So that has to be present. And what is no pneumonia? There are only URTI signs of only URTI. Okay, there is no fast breathing. There is just nasal drip, or there is just the child is sneezing. So there are no signs of infection of lower respiratory tract, and there are just signs of upper respiratory tract involvement. So these are the arbitrary categories that we have made for patients of pneumonia. Again, for pneumonia, the investigations that we do is chest X-ray. Chest X-ray will show you air bronchogram. Then if it is a bacterial infection, it might show you a lobar involvement. Klebsiella has which specific sign? Please comment down below. Klebsiella pneumonia has a very specific sign on the X-ray. If you have already commented, I will tell you it is called as bulging fissure sign. Now, sometimes in X-ray you see presence of abscesses or bullas. So if that is present, you have to suspect the presence of staphylococcus. Staphylococcus usually causes all that. And if the airway is already pre-damaged, or the parenchyma is pre-damaged, and there are already presence of places where fungus can hide, then you see aspergillomas. And for that, the investigation of choice for invasive aspergillosis, the investigation of choice is beta-1,3-glucan. That is the diagnosis for the fungal infection, systemic fungal infection. So you have to keep that in mind, that lobar involvement. Then again, there might be a pattern of bronchopneumonia or hazy involvement that might suggest of a viral involvement, or there might be atypical involvement suggestive of mycoplasma or chlamydia. Now, what are the blood tests that we might do that might suggest? So there is increasing WBC count. Again, if neutrophils are increased, we suspect bacterial. If lymphocytes are increased, we suspect viral. Again, we have seen the exceptions that in pertussis, lymphocytosis occur. So polymorphonuclear cells are increased CRP and procalcitonin. Now there has been a considerable debate about there are the acute phase reactant for sepsis or bacterial infection. So which is a better inflammatory marker or acute phase reactant for a systemic bacterial infection or neonatal sepsis or pediatric sepsis? Then the answer is procalcitonin and not CRP. It has been written in Nelson that procalcitonin is more sensitive and more specific compared to CRP. So procalcitonin might be increased. And for viral pneumonia, you might suspect viral when there is increased wheezing. And younger age and lymphocytosis, and generalized involvement of the lungs. Now, some two more features might be present with viral pneumonia, and that might be signs of URTI. That sometimes if URTI is associated with LRTI, it is more likely that it is viral and not bacterial, and if it is associated with diarrhea. So if you have not yet given antibiotics and patient has diarrhea also, then it is more likely that it is a viral cause compared to a bacterial cause. Now, for chlamydia and mycoplasma, we do a nasopharyngeal swab PCR. We do PCR for nasopharyngeal swab. The same that we did in COVID, you remember the nasopharyngeal swab. So same sample we take for chlamydia and mycoplasma, and even for the dreaded swine flu, the same sample we can take. So we have to do PCR, and once PCR is done, we'll get the diagnosis of the virus or bacterial infection that we are, we are dealing with. Now, what is the treatment? So treatment of pneumonia. Treatment of pneumonia. So firstly, we'll see that viral pneumonias are usually with respiratory syncytial virus. Now for respiratory syncytial virus, you might know an antibody called as palivizumab. Now that is for prophylaxis and not for treatment. So for treatment for viral pneumonia, if it is not severe, then it is just symptomatic, and you give humidified oxygen to the patient. You give humidified oxygen to the patient, because if you do not give humidified oxygen, what happens is you are giving dry air to the respiratory system, and dry air is damaging. Just the way that if you do not keep the moisturizer on your skin and you go out on the bike in winter, you realize that your skin gets your lips and your skin, they become flaky. So that same thing happens when you give non-humidified air to the respiratory system of a younger child, which is more susceptible to damage compared to the adults. So for pneumonia, if you suspect that if it is swine flu, we know we give oseltamivir, we give zanamivir, and for pediatric also we may give, and for prophylaxis also we give oseltamivir, and for COVID-19 again, there has been significant controversy and the guidelines have been kept changing, so we'll not comment on that right now. So for treatment of pneumonia, if you suspect atypical infection, you have to go for something like erythromycin or azithromycin or doxycycline, because again they do not have cell wall, and if you give ceftriaxone third generation cephalosporin, you give penicillins, and the patient will not get well on their own. So you have to always keep in mind that if it is an atypical infection, you go for beta lactams. Now then, macrolides, you go for macrolides. Now what is the treatment of choice? Treatment of choice for community acquired pneumonia in a bacterial infection. So we will divide it into two parts. So one will be presence of high risk, and there is no presence of high risk. So what might be high risk? The child is younger than 2 months, or the child has severe respiratory distress, or child has apnea, grunting, child has immunodeficiency. All that are high risk. So if you suspect presence of high risk patient, then what you give is, for a non-severe, again we'll divide it into two parts. So for a non-severe, the first line is amoxiclav, or commonly known as augmentin. So you can give amoxiclav, and if it is severe, then third generation cephalosporin plus aminoglycosides. Now you have to keep in mind that Pseudomonas. So for that, again, the treatment of choice is third generation cephalosporin and aminoglycoside. You can give piperacillin, tazobactam if you don't have that. So this is the treatment for the first line, and if it is not high risk and the patient is non-severe, then you just give amox to the patient. And if the patient has severe, then again you give ampicillin, gentamicin. So this is a general treatment of pneumonia. You have to keep in mind that you have to begin with amox if the patient is not serious, if the pneumonia is not severe, and you do not have to panic and start patients on vancomycin since the first day of community acquired pneumonia. And this is all about treatment of community acquired pneumonia, and we'll go through vaccination when we go through the individual lecture of pneumococcal vaccination. The next part is the more difficult part, and these are the specific pneumonias. So first one is health care associated pneumonia, HCAP, health care associated pneumonia. So it is a pneumonia in a patient who was hospitalized for more than or equal to 2 days in last 90 days, or patient has visited OPD or dialysis or IV antibiotics or chemo. So it is not exactly an outpatient, or it is actually daycare. Patient has daycare exposure in last 30 days. So essentially it signifies a patient who has been in contact with a hospital environment but who is not admitted there at present. So that is healthcare associated pneumonia. The second is hospital acquired pneumonia. So hospital acquired pneumonia is you have a pneumonia after more than or equal to 48 hours of admission, and the infection was not incubating, not in incubation period when the patient got admitted. So the infection was not incubating, the pneumonia was not incubating when the patient was admitted. And the third one is ventilator associated pneumonia, which occurs after 48 hours of intubation or invasive ventilation. It is not valid for non-invasive ventilation. So these three are the common definitions of three of the hospital related pneumonias. So these three are them, and the most common organism are the gram negative rods. So these are usually something like Pseudomonas, Klebsiella, Enterobacter, Acinetobacter, and the most common second close by is gram positive cocci like Staphylococci. Now this infection, how do they differ from community acquired pneumonia, is that this usually tend to be multi-drug resistant organisms, because in hospital we have these infections, or this infection that have festered and persisted in a hostile environment like a hospital makes them more stronger. Like Nietzsche has said that whatever doesn't kill me makes me stronger. So these infections which have festered inside the hospital are usually multi-drug resistant, and they are more dangerous compared to the other pneumonias. So how do you diagnose hospital acquired pneumonias? So what are the hospital acquired pneumonias that you see? Usually what we see is that x-ray picture is deteriorating. Like when you admitted the patient had no patch. After 48 hours patient develops signs of pneumonia, fast breathing, respiratory distress, fever, and all that, and you do x-ray and you see that now the patch has developed. Initially it was not there. Okay, so that is how we diagnose the patients of hospital acquired pneumonias. Now, there are also ventilator associated conditions and ventilator associated disease, but that is too much into detail. This is important part. Now, for diagnosis in these patients, culture and sensitivity is important, because again, I have told you that these organisms are not the routine garden variety organisms. They are the fighters and survivors, so they are usually more dangerous. So what sample to take? So how do we take the sample of culture and sensitivity in the patient? So there are four methods. One is endotracheal aspiration. Endotracheal aspiration. Like what do? We take when we detach the ventilator, we put the Riles tube or any tube, we suck out whatever comes out, and we keep them. We go send it for culture sensitivity. The second one you can do is a protected brush sample, and this is the best sample actually and least contaminated. See, endotracheal aspiration is the most contaminated sample because it is usually contaminated with the things that you keep the things that are in the endotracheal tube or the oral flora. So it is the most liable to most contaminated, but it is the easiest, while this is the most difficult and least contaminated. Okay. The third one is broncho alveolar lavage, and the fourth one is non-broncho alveolar lavage. Essentially, what happens is you go inside and you push saline, and you with the catheter, you go inside the catheter, you put the catheter inside the bronchus of the patient, and you push NS, and then you aspirate all that you can aspirate, and you send that for sample. So that is what the methods are, and the sensitivity range from 10 raised to 4 colony forming units per ml to 10 raised to 6 colony forming units per ml. So there is variable sensitivity in all this, and there is no general consensus on what sample to take, but I have told you the advantage and disadvantage of each and every thing. Now, in these patients, prevention is more important than cure because these organisms are dangerous. So, how do we prevent this pneumonia? So, first one is careful suctioning. So, the if you do not use a proper Riles tube or proper catheter for suctioning, what happens is you are putting the organisms inside which are not present. So you are creating infection. So it is a 2% job, and there are closed suction systems in which you do not have to detach the ventilator from the patient. You can directly put it from a side port. So nowadays that systems are available, and they are very, very helpful in decreasing the chances of ventilator associated pneumonia. The second one is proper technique of ET tube insertion. Like you are doing intubation, the ET tube falls out of your hand, it falls on the floor. You take that ET and you intubate the patient. So what happens is that you are putting an infection inside. The third one is oral care, proper oral care. So, proper oral care. So, why it is important? See, what happens is there are something known as micro aspirations. What happens is that these patients are sedated, these patients are paralyzed, so they are unable to swallow their own saliva. So this saliva goes inside the trachea, and it causes micro aspirations. So oral care is important, that if the flora is present over here, then it might go inside the trachea if you do not take proper care. Okay, so that is proper oral care with chlorhexidine and even betadine mouthwash are recommended. Now, using of Hme filters. Hme filters are, they are very effective in preventing pneumonias because they do not allow the flora that is present inside the ventilator tubing, which might or might not be sterile, to go inside the endotracheal tube. So it is a very effective method of preventing pneumonia. Then use of H2 blockers or PPI. Now, how are these important? So, sometimes the patient has a head injury and or a burns. You think that you have to prevent the ulcers in the patient, Cushing's ulcer or Curling's ulcer. So what you do is you prevent them with H2 blockers. Now, what happens is this acidity that is present inside the stomach is very effective in killing bacteria. Now, when you block it, if you increase the pH of the stomach, what happens is that when the stomach content gets micro aspirated, it might contain bacteria which was not killed by the acid. So these H2 blockers and PPI have a negative role in patients of intubated patients, but There is one antacid known as sucralfate. Sucralfate does not decrease the pH of the stomach; it increases the barrier function. So it is beneficial in preventing ventilator-associated pneumonia, while H2 blocker and PPI may cause ventilator-associated pneumonia. So you have to keep that in mind. And the last and the most important part is elevation of bed to 30 to 45 degrees, so which might prevent aspiration. Again, you have to keep in mind the basic things like hand hygiene is most important, wearing of gloves, then early extubation of the patient. And there are bundle approach. So what is bundle approach? They have formed pre-made guidelines that you have to follow, which might prevent the ventilator associated pneumonias, and it has helped immensely. So for with that out of the way, we have reached the end. Now for the treatment again, you see the treatment is organism wise. Like if you find MRSA, then you have to give the treatment for MRSA. If you have VRSA, please do not give daptomycin. Daptomycin is the antagonist of surfactant. So for Staphylococcus pneumonia, you have to give linezolid, or else all other causes of VRSA, the drug of choice is daptomycin. So you have to keep all that in mind. Then you also have to give Pseudomonas or Acinetobacter cover, but the important therapy should be guided according to the culture and sensitivity report, and that is the final thing. I guess that's all for today, guys, and I hope you like the video and you got to learn from it. And if you like the video, please comment down below, like, share, and subscribe. And if you want me to cover any topic under the sun, I'll try my best to do that. And I'll see you in the next one, and goodbye.